Rocketron.
Thicker and they're on nitric.
And they're on nitric, right? And that's the difficulty, right? Because we're not using it all the time, but when we do, they're thicker, so we're having to kind of manipulate it very quickly. So, first part is.
Let's see if I can find a spot to get over here. I'll leave it. Maybe if I can put this right over here. Move it on.
As far as the way it works, though, it works just like the older TXP that we have on our isolate.
It does.
It looks exactly the same, just newer.
It just has the multimeter, right? Because you guys got updated with the electronic manometer.
Yeah.
So, and then the shape of it. But as far as functionality with the frequency and the amplitude, it's still gonna work the same, right? I wasn't told of any kind of differences on the PSI as far as it being preset. So everything there should be pretty close to what we're used to. And then we'll talk about the nitric with the bleed in and how you guys are doing it. Okay. So the first thing with this is, it may seem a little redundant, but I'd just like to make sure to cover the Venturi setup, just so that there's clarification on this and all the respects of it, right? IPV as a whole, it really just builds on top of itself from the therapy devices, even the ones at home, up through the ones that are in the hospital, and then of course the TXP, the transport Rocketron, and then even the VDR, right? It's all based off the same premise of the sliding Venturi, right? So that's the one piece that doesn't change. So basically what we have here is high velocity bursts are going to be coming from the device that we're going to be controlling with a combination of amplitude and the frequency of the burst, right? It's going to fire in through the Venturi, activate the valve forward, the sliding Venturi forward, and then it's going to allow time for it to reset, right? And each time, so it's not actually pulling anything negative, it's not creating any negative force with it. Exactly, it's just resetting. The high velocity burst, once it gets transmitted through, it goes through a couple different phases inside here. All right, so first part diaphragm. Next part, you guys will notice it kind of narrows out. So that small funneling shape is just to really increase the velocity. Just picture a river, right? Stream narrows, velocity burst gets really fast. At that point, there's empty space between. So that's where the entrainment is allowed. The hole here is like a funneling shape. It's a specific diameter. It actually starts out narrower and then gets larger. So that it can entrain, and then also as it's entraining, it's pulling in a larger subtidal volume. Those subtidal volumes are going to be adapting based off of entrainment, right? So each burst is a different size. Now, one of the key differences between this and any of the other IPV devices is the fact that we have a PEEP valve on here, right? So we have some resistance to exhalation. And this, for better or for worse, is sometimes it can be a great benefit, but it also can be a hindrance on some of the patients, right? And we'll talk about how we can see that happen, especially with chest wiggle. The more we crank this down, we'll increase the map. Usually we teach it as far as being able to adjust the map with this, right? But inherently, we all can understand, we're creating like a static resistance, it's increasing PEEP, so indirectly your map's gonna increase, right? The more of this that we have, the harder it is for the patient to exhale, the tighter the wiggle gets, right? Or we can kind of start losing wiggle. So what tends to happen is if we have very high amplitudes or higher amplitudes, then we start to find ourselves in that position where some of our larger patients, we can start to kind of lose that wiggle. We're kind of battling between the two, right? And we'll talk about how we counter that with the frequency. But inherently, that's always the crutch with just this, right? And of course, the reason for this is just to really conserve gas, okay? So in an ideal situation, this would be as open as possible if gas was never an issue, right? So you can see entrainment always happening here. Green valve is just to pop off in case there's any excessive pressures, okay? And then we have our TP set up. The nitric bleed in, and we can hook it up if you guys set up the device.
This one here, we don't have the Aeronox. We're getting the new Aeronox.
You are?
The Gen 2.
Okay. what you'll find with this particular connection is that because it's being introduced and sampled on the same side, this is the same one you guys use, right? Okay. The timing for that, first thing is, it's not the ideal situation, right? But it's necessary for those patients. If they're on nitric and they're sensitive to nitric, you're not gonna be able to take them off, okay? But the first thing is, because it's introducing nitric through here, and it's sampling at the same point, and that flow that's being introduced is coming in after the venturi. That's what sometimes can cause that we just have to be aware of with possible additional air trapping, because the venturi can't calculate for that extra flow that's being introduced, right? But again, it's one of those things. So we want to get by with the least amount of flow that we can, depending on what those concentrations are. If you have lower, like 20 parts per million, you're going to be much more successful than if you have a patient.
That's all we do is 20 parts.
Okay, and that's typical.
Yeah.
Therapeutic.
Yeah.
Yeah. But as soon as you have to dive into a higher realm, that's when things get very difficult. So.
We don't go past 20 usually.
Okay.
Ever.
Perfect. So, connection itself. Any questions there with just the overall? Okay.
Do those need to be waxed?
You know what?
These are the
That's the
disposables, right? So
disposable,
they
that's why I'm
shouldn't be.
asking. I'm just curious.
This itself doesn't have to be waxed, but the permanent ones you usually would.
Yeah,
So
she
you're
has
talking
this
about,
little
like,
I was
video.
just curious.
We have some of the older
Okay.
ones that
Yeah.
do, but
And I was gonna say, if you guys don't have, I mean, I can always give you guys a couple. It's
Oh no, we do. I
like the
just wasn't
lubricants.
sure. Someone we pulled out a new one, we set it up, and they go, "Should we wax it?" And I was like, "I don't think so. It's a disposable. It should be okay." I was just curious.
Okay. Yeah. No, that's still same kind of train of thought. So.
But you can if you wanted to.
Yeah, you can if you want. It's not gonna do
Whatever.
anything.
Okay.
Um.
I'm listening.
Yeah. Exactly.
Yeah, one less thing not to worry about. Yeah.
So it won't do anything wrong with the device if it doesn't. So let's fire this puppy up, and then we can talk certain scenarios. Has there been certain patient populations that when you guys have done this has been a little more difficult than others? Obviously with the nitric being said, but
as far as the ones I've picked up and stuff, I wouldn't say that there was one that was necessarily more difficult than the other.
Dang.
You having trouble?
yeah, so I got fat fingers. I
I
got
mean, the ones that we're gonna use that mostly on are your D hernias and meconium.
Meconiums.
aspirations.
So ones in
PPH
LVI,
in.
And
okay. Okay.
sharp jacket, bro.
Thank you.
Do they have a little piece to make that clear line an L to make it easier to put it on?
That's just the way it comes.
Yeah.
Yeah. This is. I feel like this is new. Like the position of this with this bar. It changed the bed up some, right? Like the.
Mm,
I don't know.
no, that's the way, because
stretcher
it's got
that
the
changed
clips
the-
on this side over here.
Oh, it
So,
is? Okay.
and it's clipped on the other end there too. I don't know if they've redesigned it
Yeah.
or what, but it's a brand new one.
Okay.
So it's not pinched.
No,
It's not
It's
pinched,
turned, but it's
It's
closed.
not
Close.
pinched.
Yeah, I would just.
on a warm day.
Yeah, I would just kind of check that out.
Where it plugs in because you have to go over that bar.
Yeah, there's that.
okay, gotcha.
Even the bottom's going to be more of a kind of crease. So, oh, and then another thing too, because I know I mentioned this with Jerry, but so I do all the education with all the other devices, including the transport bronchotron. This specific one is designed for international medical, biomedical. So I can still talk theory and I can talk, but actual application of this particular one just on patients is more theory based. Like I haven't done it personally on those patients, right? The difference between this one and the transport bronchotron, if you guys have ever used it, is the briefcase one, right? So still very similar, but the limitations on this really is because you have a fixed PSI inside, and the fact that you won't get as much output. So that's why when you get to those larger patients, you sort of can pitter out, right? You just won't have enough.
What's a larger patient?
Well, typically you guys are doing NICU, but if you guys are doing like that kind of crossover, NICU, PICU, like, I don't know, 10,
We're gonna be
10
keeping like
kilos.
5
Are they
kilos.
small?
Yeah,
I
I'm
was
Five
gonna say,
kilos
are
or
they?
less.
Can we pick them up and put them on our stretcher, or are they just big enough to stick into the
Yeah.
isolate kind of kid?
Yeah.
Yeah.
And you'll know those ones. When they get a little larger, because what you'll end up having to do is you'll start maxing out your amplitude, right?
Okay.
And then you'll get to that point where you're just,
What, 5 kilos? 5 is what we.
yeah, if 5 is like kind
5
of,
and a half.
You
5.
got some idea,
Yeah.
we're sitting there.
Yeah, they were like, oh, let me out.
hey, I usually say like 8 to 10
They're
kilo
talking to you.
and
Yeah.
above is when you start,
Like
and it's
this.
like some of the larger meconiums of,
But I mean size wise.
So,
Well, I guess there's one. Okay.
all right. And I'm just gonna include it for now, but do we have
good.
a small Tesla?
Test one?
Yeah, like a little
Oh, he
mini one.
took the other one.
In the other isolate, there should be one.
Or where's the
Go get
box? I think maybe there was in the box there.
This box?
You want to grab one, Mikey?
Yeah.
Oh, sorry,
yeah,
you're
on
right
the
there by the
isolate,
door. Sorry, man. He's gonna go grab one. I
I don't know.
guess.
It's all right. Yeah, this will be fine.
He's getting you along.
Okay. So for those of you guys, has everyone here actively used this? Yeah. Okay. Any
Well,
thoughts
then
or feedback on it?
You mean the new model?
I would just go through it still.
The only thing that really has changed is the other one was vertical. That's the one you guys had,
Yeah,
right? The
yeah,
vertical.
the little box.
Ours is
Yeah.
Right. That's all that's changed. This is still going to be providing you. You're still getting the map, and then your peak pressure is showing up on the top side, but you also get it from the bar. Should be. I always just use these numbers anyways. And then you see above the frequency? So you get your map and you should get your peak. I will double check on that, but it should be your peak. Because on some of these, they've been adjusting these, and sometimes they'll come out with updates without telling us. But sometimes they'll have one that's called an AIP, an average inspiratory pressure, and then an average expiratory pressure. And so you'll see that, and basically what that really is they cut the respiratory cycle in half, right? So during the inspiratory phase, that inflection point from the top and the bottom, it gives you that average. It's somewhere close in the middle. It's not dead center, but it's pretty close. And then same thing with the expiratory. So it's not a true peak per se, but it'll be what they consider an average. Clinically, I haven't found that extremely relevant yet, right? Because it's something that's been in practice better part of over a year now, like going into 2 years, but it's still, everything is kind of map driven. Really the only thing that we can associate between different types of ventilation, whether it's bi-level or conventional oscillator, is really kind of map driven, right? The way these pressures are being produced and delivered is much different. So one of the key things is when we initially set this up on our patients is really based off of our assessment.
Thanks, Mike.
And one of the key things that will also change as we're assessing our patient and doing it is what our gas sources are, right? So you guys are probably noticing when you're switching them between the wall and then your tanks, knowing what those tanks and how they typically react. If the tanks are, for whatever reason, a little bit higher, right, it's not dead center 50 PSI, let's say they're 55 or the wall is a little bit lower, that's going to shift all your numbers up, right? Or adversely affected as well, right? If the tanks are lower regulator pressure, then everything gets kind of cut down, okay? So it's good to really know that side of your equipment, and then know if you see something in the hospital, even though it's supposed to be 50 PSI, they're usually pretty good for larger hospitals. Some of the smaller ones I've been to, sometimes they have old connections, right? So with that being said, initially, when we're working with our amplitude for our pressures, for our patients, right? The amplitude is controlling the flow or the strength of the percussion, right? It's the inspiratory flow that's being introduced. So the more we increase here, the stronger the percussion gets, okay? This is gonna be first and foremost the key in order to begin to set your map. The rest of it's gonna come in with the peak that you're gonna add in, okay? When you begin to do that, you'll see the dynamic of this start to change because of the resistance that you're adding, all right? So one of the things that's going to happen in combination is really the assessment of it, going back to that, is getting an effective chest wiggle. And the chest wiggle we're really looking for is more from the nipple line to the apices. If you see it like the oscillator, if it becomes a full belly wiggle, I can almost guarantee you're going to wash out too much CO2 and patient's not going to be tolerating it too well, right? Typically that'll happen at lower frequencies, right? So that's something else to be aware of. Most of the time we're dealing in the, I would say the mid 500 range. And on that paper, there's some good examples as far as different disease pathologies that kind of give you some starting points. It's all based off assessment though. So the first one visually is you see your chest wiggle. The next one is going to be palpating on the patient. You know, they're small babies, but even by kind of feeling around, you can kind of feel the percussions are happening. If you have an x-ray to base that off of, depending on what they have inside, right, happening in the lung, it's going to be a big key, especially with patients that are utilizing nitric. A lot of times the babies they're consolidated. They have some, you know, severe atelectasis happening that they're trying to resolve. It's usually one of the first things that we can resolve while we just put them on. And you guys, I assume you guys do like the 30-minute rule kind of when you first put them on, like 30 minutes, do an ABG, and then get them ready to ship out. Is that pretty fair?
Yeah,
More or less.
For the most
more or
part.
less.
More or less. Okay. So those are some of the changes. Shooting for, you know, just initially seeing what that chest wiggle is like, that's going to help you kind of preset everything before you get your gas, right? So it'll kind of enhance your time frame. Right now I have a very large map. We're going to exaggerate some of the processes with this, but just so you can even see the fluttering that happens, depending on the lung capacity, is going to determine how much is actually in training in this, right? If there's more lung space or less lung space, this will entrain almost to nothing, right? And that's really the premise of what keeps this safe for the patient. The high velocity burst is energy, very small subtidal volume, but if there's no space for it, it's not going to be entraining much of anything, right, to protect the lung, because the lung isn't quite ready at that point to be able to open up. Not until the lung starts to open up and stabilize. The only way to stabilize what's been recruited is by training more volume, right? And at that point, that'll drop your pressure automatically. You'll see that happen. So sometimes with these test lungs, it can.
Yeah, that, you know, you mentioned entrainment, and I wasn't aware of it till you mentioned it when I was studying the IPV in service a month and a half ago. Is, you know, we're measuring the sample gas that goes back to the aeronax, and you see an FiO2 reading there.
Correct.
You know, you may get big swings in what that's actually reading, but it's totally dependent on what's going on here. So you may have it set at 100, but it's only reading 70, depending on what this thing is in training as far as room air.
Yeah, that is a great point right there, and that's one of the difficulties sometimes that comes up with this, right? Is that in any, you know, scenario, really, we're never really delivering 100.